All right, good morning. My name's Mary Leonard. I'm chair of the Department of Pediatrics. It's my great pleasure to welcome you to Ground Round. As always, we love to see people here in person, and we do have breakfast, but I know as always, we have a good turnout online. All right, on the first slide, I just want to call your attention to the sort of housekeeping on the left, the text codes to confirm attendance for CME and also to be eligible for the American Board MOC Part 2 credit. And then, as always, want to call your attention to the wonderful lineup of speakers. Our own near and dear, Paul Fisher, our chief of pediatric neurology, who's now the editor of Journal of Pediatrics, is going to come talk to us about publication ethics in pediatrics. He gave a talk on publication probably about 4 years ago, and it's really was an incredible presentation. Delighted that he's coming back. Tragedy, comedy, and opportunity. I'm looking forward to that. And then Sam Goldfarb from University of Minnesota Medical School is just an absolute leader in lung transplantation, and Division of Pulmonary Medicine has invited him to speak on lung injury and stem cell transplantation. As always, especially as we're back in person, we start with our university land acknowledgement shown here that we recognize that Stanford sits on the ancestral land of the Muwekma Ohlone tribe. Land was and continues to be of great importance to the Ohlone people, and consistent with our values of community inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relation to Native people. Also want to call your attention to upcoming MCHRI seminars. This is quite a combination. I think it really speaks to the depth and the breadth of the work that goes on at Stanford. And we're very fortunate to have Michael Fischbach talking on understanding and manipulating human immune modulation by the microbiome. Michael's absolutely a thought leader in microbiome research. And then we're going to hear about geopolitical unrest, how aid sanctions impact global progress in maternal and child health. Ruth is a postdoc at the Center for Innovation in Global Health, and Paul Wise is absolutely internationally renowned thought leader in children in war-torn countries, refugees. He, as many of you know, is on our faculty, but also was the pediatrician appointed by the government to go down and monitor what was happening to children at the border. So we are always very fortunate to hear from Paul. And with that, Sohail, our Chief Division of Gastroenterology.
Great. Thank you, Mary, for those introductory remarks about Grand Rounds. And it's great to see so many people actually in person, and I'm sure online. My name is Sohail Hussain. I serve as Chief of GI, and it's my express pleasure to introduce Dr. Sanjiv Sunny Harpavat, who is an associate professor with tenure in the Department of Pediatrics at Baylor. Sunny is not new to Stanford. He was an undergraduate here, graduating in 1997. He went on to do an MD PhD at Harvard, and then in 2006, moved to Houston for pediatric residency fellowship, and stayed there since. He has received numerous awards throughout his education, training, and as faculty from each of the institutions he's been at. He has a steady stream of papers. He had a K-23, has an R03 NIH grant, and he has been recognized on several levels. And I thought it was interesting that in the Texas Monthly, 2 years consecutively, he was called a Texas super doctor. And at a 2022 Newborn Screening Worldview Summit, he received the, quote, New Kid on the Block Award. So we thought it would be appropriate to invite him here. Dr. Harpavat has interest in a variety of liver diseases, including neonatal cholestasis, inherited liver disease, liver transplantation, metabolic liver disease. And his main interest is on the topic of today, which is a newborn screening strategy for biliary atresia. As you conceive of questions or comments, please either post them on the Q&A, and for those who are here, there'll be an open mic. Please join me in welcoming Dr. Harpavat.
Okay, thank you, Sohail. And thank you for everyone for inviting me. It's really an amazing facility. And I think I've said this so many times to everyone I see. You guys have it really good here. And it's fun to be back. Okay, so today we'll talk about a newborn screen for biliary atresia. Before we start, I'm part of the AP SOGHN section on gastroenterology, hepatology, nutrition, and we've started this new initiative. It's a bit like the landslide you heard about at the beginning. This is a commitment slide, and it's a dream of space, specialty access for children everywhere. I think this is a deep goal that we all share in pediatrics. And we want to make sure we acknowledge this not only at the beginning, but throughout the talk, which you'll see. The goal ultimately is to eliminate uneven care and health disparities by improving the way referrals are made to us as specialists, how we diagnose the children, and how we treat them. These are my disclosures. I am on a DSMB for a biliary atresia trial, and I'm the NIH support like Sohail and philanthropy support like Sohail mentioned. So I'll start with acknowledgements. This is a big project, and there's a lot of people that many people probably know in the audience that have helped with this. Ben Schneider at the top, he's a pediatric hepatologist who really helped see this through, but lots of people from the NEO side, lots of people from different organizations. And of course, at Stanford, I put at the bottom the friends and colleagues I've had. And Amrita, thank you for actually inviting me to share this. So the question I hope we can talk about today is which diseases deserve a newborn screen? So if you think about it, every single baby in the state and in all 50 states, before they leave the hospital, they get their heel pricked, some blood goes on a spot, and it gets sent in California, I think, to 3 laboratories, in Texas to 1 laboratory, and the blood is analyzed, and it's analyzed for diseases. And so from a pediatrician perspective, from a public policy perspective, from a parent perspective, you want to ask the question, what disease deserves to be screened for from that blood spot? And so, as you can imagine, people have thought about this deeply. And I like to look at this, a paper from 1974, before we had really fancy techniques. There was a Dr. Frankenberg from Minnesota, and in pediatrics, he posed a question, and he came up with some pretty simple criteria. And I think we can probably agree on this criteria. Of course, we can add more if we want, but the disease should be important, relatively common, and amenable to early treatment. And once you've got that disease, well, that's great, but then you need a test, and the test needs to be acceptable, reliable, valid, and of reasonable cost. So in this talk, what we're going to do is we're going to use this outline to basically evaluate a disease that I think a lot about, and I would argue anyone in pediatrics ends up thinking a lot about, whether you know it or not, called biliary atresia. So objectives: determine whether biliary atresia is a disease that deserves a newborn screen. And once we do that, also evaluate a new screening test for this disease. And I put this little outline in the upper right corner so we can follow along and keep the logic going. So number 1, is biliary atresia an important problem? So what's defined as importance, Frankenberg said, should be serious or potentially serious. If it's not, like if it's acne that you're going to develop at age 12, probably don't need to screen for that, right? But we're talking, and that can be serious. I don't mean to belittle that. I have some teenagers right now, but we're, serious. I think we all can agree what is serious. And so this is really important. I made the claim that we all think about biliary atresia to some degree, even if we're not pediatric liver doctors or surgeons. And this is why. This disease is the #1 reason for solid organ transplant in our field. So it's the #1 reason for liver transplant in our field. And astonishingly, in less than 1-year-old, 60% of all liver transplants go to a single disease. I don't think you could find that sort of dominance in any other field. But it even seeps over, because these numbers, it even seeps over to all organs. And for those nephrologists in the crowd, cardiologists, pulmonologists, anyone who does solid organ transplant, you ask your transplant surgeons, Stanford, the leading transplant center in the country, biliary atresia is going to top the list for most number of solid organ transplants. So what is this disease? It's actually quite easy to conceptualize. You can see the picture of the baby's abdomen. You've got the liver, you've got the green tubes, which are the bile ducts, and you've got the intestine. And the liver makes bile. The bile goes through these tubes into the intestine, digests fats, and helps us grow. And in biliary atresia, just as the name says, the bile duct is atretic. The bile can't get out. And the way we can reason this is the child not only doesn't grow because they can't absorb fats, but the bile backs up. And now something that's supposed to emulsify fats is ending up collecting the liver. That can't be good, and the liver gets destroyed. So this disease is a really fascinating disease. It starts insidiously. What I mean by that is babies appear normal at birth. They don't appear to have any problems. And on the left, you see what's depicted as a normal baby color. In the stool, because it's receiving bile, a normal baby has yellow or pigmented stool. The bile pigments it. In biliary atresia, over the first 2 to 3 months of life, the baby ends up appearing yellow, and the stool, which no longer is receiving bile, ends up turning pale. Now, like I said, you guys have it good, which starts from the quote unquote bottom. You've got good medical students. So the question that came up from the medical students was, what about that AST and ALT? Well, look, this is the transaminases in kids with biliary atresia. X-axis is age, days, y-axis is ALT. And the key thing to note here is at the very beginning, in the first 30 days or so, like I said, these babies appear normal. And if you were a primary care doctor, a diligent primary care doctor who was concerned about something and drew an LFTs, your ALT and AST would be normal. Now, of course, over time, it starts going up. But the answer to the shelf question is, it is normal in the first month of life. However, don't let the clinical picture or the labs fool you. Because when we get the tissue, this is the liver biopsy. On the left, stage 0 fibrosis, normal liver, it's a trichrome stain. It stains for fibrosis. The blue is normal. So a little bit of fibrosis around the vessels. On the right is biliary atresia at 3 weeks of life. And I think we can all notice, as long as we're not colorblind, the blue, huge highways of fibrosis overtaking the liver. This is the most rapidly fibrotic liver disease known to man. And for pathologists, if you want to play games with them, you can give them a slide of a child with biliary atresia at 3 weeks old and someone with chronic liver disease, hepatitis C, alcohol use, whatever you choose. Give them that liver and you ask them who has it worse, and they'll pick the 3-week-old. So it's pretty incredible. It fibroses fast. So more things about this disease to describe it and its importance. There's actually 2 types at least, probably more. But the idea is most cases of biliary atresia, children appear normal. In a small subset, they actually have syndromic features. This is a cartoon depicting some of those features. You can see a vein that's crossing the duodenum. It's called a pre-duodenal portal vein. A spleen that has multiple lobes, polysplenia. Ascites, so some reversal of organs. So you can have syndromic features, but most are isolated, and again, most appear normal. It's a bit of a Rubik's Cube for biliary atresia. You would think we've known about this disease for a long time. The first liver transplant in the world was done for biliary atresia. The first liver transplant, the first liver transplant period. The first pediatric liver transplant in Delhi, I was just there last week, 25 years ago, almost to the date, was done for biliary atresia. It's a Rubik's Cube, though. We want to solve it. We don't know what causes it, but we do have some human experiments to tell us some clues, some negative clues. And that is, I think, one of the most fascinating is it's not inherited. It doesn't follow in families. And the best experiments for that, of course, probably people are thinking. I know there was some twin studies with nutrition done here that really made a mark. Look at twin studies, identical twins. There's been a lot of identical twins in the past where one twin has biliary atresia, the other doesn't, but there's never been situations where both twins have biliary atresia. So it's kind of we have to figure this out, but it leads to some mysteries. So that's an overview of biliary atresia. Let's ask the number 2 question from Frankenberg. How common is it? And so this is how often does it occur? Really, the right word is birth prevalence, because for the epidemiologists out there, you acknowledge the fact that some children die in utero. So you can't really, just by counting the number of kids versus the population, really know exactly how common it is, but what's the birth prevalence? Well, the incidence is pretty consistent worldwide. So this hits all people. It doesn't matter how you look, what color you are, who your parents are, it hits all people. Might be a little bit more common in East Asian countries. In Polynesia, you can see on the far right of the world, probably the most common. We don't understand exactly why. I think more sort of concrete is the following. Compare it to the things that are already screened for right now. So today, every baby born in that nursery will have blood drawn, sent to California State Lab and measured. And where does biliary atresia stack in that in terms of common? Birth prevalence, 1 in 10,000 to 18,000 infants. So for the adult colleagues, they'll say it's rare. We've definitely had that whenever we submitted to adult journals. For us, it's actually pretty common. So this is a list of some of the newborn screening tests. And the only thing with the asterisks is more common than what biliary atresia is. So these are hemoglobin diseases like sickle cell, hypothyroidism, cystic fibrosis, congenital heart disease. So these are more common. Everything else, biliary atresia is going to be at least as common or more common than the other diseases. Okay, so point number 3 from Frankenberg, is it amenable to early treatment? So the concept here is, even though the disease is terrible, if you can't intervene early and have an effect, there's no point in screening for the disease until you can figure this out. And I think that's fair. This can be, you know, if we had parents sitting in the audience of children with rare diseases, they might not agree with that statement. And we can talk about that statement if we want. But I think if we can't provide a treatment for families, then we shouldn't screen. We should at least have something we can give them. So in biliary atresia, we do have something. And what is it? We have the Kasai operation. Mario Kasai, 1950s, a really humble person, apparently. And when you read reports about him, he definitely did not want this to be called the Kasai portoenterostomy. He just wanted it to be called the portoenterostomy, porto liver, entero intestines, ostomy connection. So what this operation does is it removes the bile ducts that are atretic and basically brings the liver all the way up to all the intestines all the way up to the liver, makes a connection and hopes the bile drains. We can talk about this operation in some detail in the logic of it, but I can tell you that biliary atresia has got just an incredible history. C. Everett Koop, who was a very famous pediatric surgeon at CHOP, he also was a Surgeon General. It took him in the 1970s to bring Kasai over to the States, show American surgeons how to do this until they formally adopted it. So from the 50s to the 70s, the surgeons in the US did not do this operation. And there's reasons why, which I can explain if we want in the discussion. But here's the point. The point of the Kasai is to delay or prevent liver transplant. And how does it work? Well, if you don't have a Kasai at all, which is in around 8.6% of the population, you're going to need a liver transplant in the first year of life. If you get a Kasai, around 50% right now need a liver transplant in the first year of life. And if you get a Kasai, around 20% need a liver transplant later, 30% no liver transplant. Now, I want to introduce you to our world in case you don't know it, but those in the ICU will know this, that option 1 and 2, liver transplant less than a year, even though liver transplant is life-saving, it lasts for a long time. It's probably the best transplant you can get. This is a horrendous proposition. Not only does it require the child to stay in the ICU for months and months at a time, but it also destroys families. The divorce rate, the first thing I tell parents when the diagnosis comes, I tell them, there's a high chance you're gonna get divorced. And the reason why I say that up front is because then it plants the flag in the ground, they realize they have to communicate, and we can avoid the destruction that comes along with all the morbidity with liver transplants before a year. I'm not exaggerating. I think the record is, and Peace might know this patient, 8 hours within the diagnosis, the dad was like, I'm out, can't handle this. Liver transplant later is a totally different proposition. We have kids that come in on a Monday and will leave on a Friday. They do really, really well. So there is really a gain, even if you have 20% needing a liver transplant later. That's a huge win from our field. So how do we make this Kasai work so we can avoid liver transplant? Well, unfortunately, as medical doctors, our medicines don't work. And maybe they will in the future. We're working hard on this, and people in this room are working hard on this. But the biggest sort of trial to date is a randomized controlled trial from Georgie Becerra, who's now chief of pediatrics at UT Southwestern. It's always nice to have a GI doctor up at the top. He led this trial, a multi-center trial, looking at the difference between steroids and placebo. And the idea is maybe there's an immune reaction against the bile ducts causing this problem. You can see the Kaplan-Meier curve, not great. In fact, there were actually more adverse events, as you'd expect with immunosuppressing a child, and no difference in survival with your native liver. So is this a surgical disease? Well, there's one thing, at least at this moment, as medical doctors, we can do to affect change. And that is we can do this operation earlier. Now, of course, we're not going to do the operation. Your pediatric surgeons are. But it's our job to get the patients to the pediatric surgeon. And if we can get them earlier, we could potentially do better. So this is a Kaplan-Meier curve around 600 patients from France. And what you can see, x-axis is time, y-axis is survival with the native liver. The higher the curve, the better. It means your children are surviving longer over time. And it's color-coded. But what you notice is the white line is before 30 days. If you can do a Kasai operation before 30 days of life, you have a better chance of surviving with your native liver for a longer period of time. And vice versa, if you do a greater than 90 days, really low shot at surviving. You're going to need that early liver transplant with all the problems. Now, this is France, but this has been shown all over the world in multiple studies in Canada, Switzerland, Brazil, Netherlands, US. They're not listed here, but the bottom line is, do the Kasai earlier, before 30 days, you get better outcomes, avoid that tremendous transplant burden. So how are we doing? I think it's a fair question. As medical doctors, how are we doing to change the transplant burden of biliary atresia? And this is what we have. The national average, Kasai days before 30 days is the goal. National average, 64.6 days. 9% of patients are diagnosed too late. Their liver is already too fibrotic to sew an intestine onto. So they go straight to liver transplant. And this is Texas Children's 2007 and 2014. You'll understand towards the end of the talk why 2014 we stopped looking at this, at least in this cohort. The average day for us was 61.6 days. So you might say, hey, great, we're better than average. Not exactly. The reason why is because almost 1/4 of kids in the Houston area were diagnosed so late that you don't even count the days of Kasai because they didn't even receive a Kasai. They were diagnosed so late, they had to go straight to liver transplant. So the question is, it's amenable to early treatment. We know that. That's in our power to change, but why aren't we getting it earlier? And it's pretty simple. This problem isn't hard to understand. It's because here's the timeline. Biliary atresia shows up with the preclinical phase, like we talked about. AST, ALT normal, stools colored, baby looks fine. And then after this preclinical phase, you develop yellowness, the primary care doctor gets concerned, stools might look pale, come to us, and then our esteemed colleagues in the front row have to deal with this very quickly and figure out, do we need to send this kid for Kasai? Now, here's the tragic part about this. So we collected stories from patients. And the reason why we did this is we give a book to the new patients so that those new patients and parents can read the stories from the old patients, and their emails and their phone numbers are below so they can connect with patients. Sometimes it's better to hear, we realize parents would rather hear from a parent, another parent, than from us, and that's fair. And so we collected these stories. It was actually a medical student who collected these stories. It was actually pretty profound. She helped out with this, and she did such a good job that a Spanish-speaking family, when it was time for that family to write to their donor family, many years later, the child got a liver transplant, they reached out to her independently and said, can you help us write this letter to the donor family? I mean, it was pretty impactful moment, and just shows the power of getting patient stories. But if you look at this book, every single account is the exact same story. It's not like one person did something randomly different and presented a little differently and a little differently. And it wasn't like that at all. Every patient, baby looks fine, maybe a little yellow, go home, put them under sunlight. Comes back at the 2-month visit, yikes, pediatrician gets scared, send them to pediatric GI quickly. Every story is the exact same. And to me, that says we can do better. We should do better. In other words, the patient isn't throwing us for a loop. So if the patient's not throwing us for a loop, they're giving us the solution. We need to figure this out. Not only that, but the tragic part of this is also this. So going back to the commitment slide, This is a picture, this is us. So it's been shown in other centers, but I really want to shine the light on us because I don't want anyone to get defensive. Maybe I'll get defensive, but you guys shouldn't. This is us. This is based on how parents categorize themselves in terms of race, their child in terms of race. And this is how fast they come to be referred to us. And I think what you can see, or I'm hoping that it comes clear, is that if you are in Houston and you're Hispanic or non-Hispanic Black, you are coming to your primary care doctor later than someone who's white, just defined as white, or Asian. Okay, this is as clear of a health disparity as you can. I mean, I don't know if there's anything clearer. There is a problem in getting certain kids to attention. Okay. So, summary for part one. Let's talk about the disease from Frankenberg. Number one, I hope I convinced you it's important. Number one reason for pediatric liver transplant and solid organ transplant in our field. It's more common than most diseases we already screened for. We have a treatment, the Kasai operation. Earlier Kasai operations are better. This is amenable to early treatment. However, we're unable to deliver that to our patients. And not only are we unable to deliver that to our patients, but we're unable to deliver it in an equitable way. So some people might get the benefit, some people might not, depending on the color of your skin, which usually, at least in Houston, will reflect what primary care doctors you end up going to after you leave the nursery. Okay. So that's the disease part. Let's go to Frankenberg's test part. So you can have a disease and you can say, this disease needs to be screened. We need to do it. We can get the patients marching, and it's actually defined in Washington at the level of the Health and Human Services. We can have the patients marching. The people in the front row know that patients whose parents, the biliary atresia, parents of children with biliary atresia, those parents will stand up and they will march if we ask them to. There would be no questions about it. These are a passionate group. But if you don't have a test, you can't just say screen the disease and you have no test. That doesn't make any sense. So the last part, or the second part of this talk, will be talking about a test. And the test needs to be acceptable, reliable, valid, and affordable. So I'm going to give you an example of one test that's out there already. This is what is in Taiwan. It was actually developed in Japan. It's in Taiwan as well, Switzerland, and Canada. And it's called the stool color card. So this is a real life shot from someone in our group now 10 years ago, which is pretty amazing. Someone in our group's brother lived in Taiwan. I asked him to snap a shot. This is the book the kids are sent home, the parents are sent home with. And as you can see in this book, there's a diagram of the liver. I don't know if anyone can read this, but I'm assuming it's talking accurately about the liver. And they give a palette of stool colors. And the logic here is if bile doesn't flow into the intestines, the stool will turn pale. And if that happens, if a parent notices it, they're supposed to, there's a fax number below, and they're supposed to fax in their information or call in the information. In Taiwan, a nation of 24 million people, which is in California, maybe a few cities, they have a central agency, and what they do is they call back the next day and they advise the parents on what to do. Okay, so the question is, will this work? I think probably if you're still with me, you're probably wondering, hey, this could work in the US. And my first instinct was, yes, it could. But the truth is, it's not in the US. And why isn't it in the US? Well, I think there's some important reasons. Number one, we don't have a centralized agency. So who's going to answer these calls? It's going to be primary care doctor, nurse practitioner answering these calls on a rolling timetable screen. So as we all know, the more you test any person, even if you're normal, the more that you test, you're going to have a chance of a false positive. It's just the way tests work. And so if you're having stools as a baby 8 times a day for the first 3 months, just you can do the math, 720 screens, the chances of you sending some calls to the primary care doctor, well, the chances of you sending a lot of calls to the primary care doctor and flooding the offices is pretty high. So that's a problem. But here's some more problems. This is a subjective test. Someone's got to make a decision about stool color, and you don't want to guess wrong. And I think the most important issue is sensitivity. If you have biliary atresia, you test positive. That's definition of sensitivity. 77% of the time, that's true before 30 days. So it takes time for the stools to turn pale. 30 days is our goal. 45 days, you're doing a little better. Maybe at 60 days, it's acceptable. But again, our goal is to get them before 30 days. And so this falls a little short. The spirit of newborn screening in this country is to catch kids before they develop symptoms, not after. The reason why you do metabolic screening is not so that you can get a child coming to the ER with seizures and change their diet. It's before they develop symptoms like seizures. Of course, this type of screen, looking at stool color, relies on symptoms developing. So I think we could do better. And I'll invite you to sort of think through the logic of how we approach the problem. We approach the problem saying, if we have to pinpoint when biliary atresia starts, that's when we want to send them to their primary care doctor. And to figure out when it starts, we have to figure out some marker or anchor in the first few weeks of life, because these kids appear normal at birth. And certainly the current thinking or the past thinking in the field was this disease starts sometime after birth in that period, that magical 2-week period. So we said, before we jump into that complex problem of trying to find some landmark point in the first 2 weeks, let's just be absolutely sure at birth these kids are normal, as was assumed. Now, how do you do that? You check their liver enzymes and see, or their liver tests to see if they were normal or not. But of course, newborns don't get blood test liver numbers done. No one would universally draw newborn liver numbers on newborns, except the liver doctor can thank the neonatologist for this one, because the neonatologist concerned about kernicterus drew total bilirubins, at least in Texas, routinely draw total bilirubin levels on all babies to decide whether or not phototherapy is needed. And with every total bilirubin, to get a total bilirubin, actually before you get a total bilirubin, in the actual test, you measure direct bilirubin first. And direct bilirubin, which is in bile, is in fact a liver number. So little did we know or appreciate, every single baby was getting an assessment of their liver and no one was paying attention. So all we did was go back and call the birth hospitals for all the children with biliary atresia, and we asked them, what was the bilirubin? And the birth hospital called back, and they responded back and they said the total was this or that. And we said, we're not interested in the total. What was the direct bilirubin? And then sometimes you'd hear a pause at the other line, and then they would tell you. And this is what we found. Every single baby, you can see on the right, without fail, with biliary atresia, has a high direct or conjugated at birth. Now, this observation really pushed our timeline for biliary atresia to be in utero. To no longer think of this as some magical or weird disease that has a critical window in the first 2 weeks, and then it forms. This is a disease that starts early. These babies have signs right at birth. Now, that's from a scientific standpoint to understand the disease. But from a more practical standpoint, how can we help our patients? This tells us right away we have a very sensitive test. If you have biliary atresia, you will have a high direct or conjugated at birth. Okay. Now, a test being sensitive is good, but it also has to be specific. You can't have a lot of false positives. And so the trick is that the conjugated bili rises with time. And so the simple way to do this, to get rid of any potential false positives, is to simply retest the child at some later date. Every child in Texas gets seen again at 2 weeks of life. And so gets retested at the 2-week mark to make sure the bilirubin did not go down. If it went down, it's fine, but if it's continuing to be high, come and see us, let's evaluate. And so you can imagine now, a very complex problem can be distilled to a very simple potential solution. A prospective screen for this test, you get a newborn test, you get a normal level, leave them alone, a high level, recheck at 2 weeks if it's still high. Let's check them out. We did a pilot quickly at 4 hospitals. In Houston, at least one of these hospitals will represent the hospitals you guys care for. You can see they differ by private, public, race, ethnicity, prematurity, and whether or not they do a conjugated or direct, which I will talk about. And but most importantly, every baby got tested, and all the referrals would come in this area comes to one central hospital, not unlike here, where we're kind of the big show in town. So we're the tertiary quaternary care center in the Houston area. And so here are the results for this test. 11,000 newborns on a pilot, 121 were high, 114 retested, 11 were high. 2 ended up with biliary atresia, 1 with another condition, alpha-1 antitrypsin, we care about still. And then 8 of them were blood disorders, too much lysis, liver does not need to see this patient. We can tell you right away without further testing that we're okay. We don't need to see the patient. So let's evaluate it. So is it acceptable? Is direct or conjugated bilirubin acceptable? So how did Frankenberg describe this? Acceptable to the person who will be performing the screening, which will be us, to the children to be screened and their parents, which are of course the babies, people we serve, to practitioners, medical and non-medical, basically society. Is it acceptable? And now I am not, in this case, giving you answers. I'm really inviting the conversation. If I was giving you answers, you guys would already be doing this. Everyone would already be doing this. Really, this is the time where, as a group, people that are willing to push the field, which we all are, try to make it better without harming, I think, which we all are. This is the invitation to start the discussion. So is it acceptable? I'd say yes, but maybe not. So if you noticed, for those of you who sort of saw the details, 121 tested high. In the pilot, 114 got further testing. What happened to the other 7? Well, 3 of them died, so they're not going to be retested. But 2 missed follow-up. They couldn't get to their primary care doctors for transportation reasons. And this, admittedly, is a very low number because we were deliberate about having kids follow up. And 2, I don't know if you guys ever received this, but there's certainly people in this field that are much more experienced than me and much more experienced than many of you. Now, maybe some of you guys are the ones that carry old knowledge and, you know, sort of help our field not make mistakes. I'm certainly not one of them. Maybe someday I will be. 2 primary care doctors that were much older said, forget this. We've never heard of this, and we're not going to test anyone again. Okay, so it clearly wasn't acceptable to 2 primary care doctors in Houston. Okay, is a technology reliable? And Frankenberg defined reliability. Is it consistent? Can you get it over and over again? Does the test work? And for that, I hope so, right? We use direct bilirubin and conjugated bilirubin measurements. We've been using them for at least 50 years. The one subtlety I will sort of leave you with, I think it's worth keeping, is not whether or not this test is reliable, but just to understand what you're using. So there's actually a difference, direct versus conjugated. At Stanford, you guys use direct. We use conjugated. Multiple different machines in your lab, Roche, Abbott, et cetera, will measure directs. Only one type of machine measures conjugated. The direct uses a chemical reaction, so a color reaction, you measure the amount of color, whereas the conjugated actually measures the exact amount based on optical properties. And the direct measurement, and this is sort of upsetting maybe for some, but I think it's important to share, the direct measurement not only gives you conjugated, but it also gives you a little bit of, it gives you all of delta bilirubin, which is old conjugated bilirubin that binds to albumin. Think of glucose binding to hemoglobin and hemoglobin A1Cs. So it's the same idea, conjugated bilirubin binding to albumin, and that is delta. And then it actually measures a little bit of unconjugated. So that's not great because babies, of course, have high unconjugated, most of them after birth, whereas the conjugated measures only conjugated. And so this classic scenario, quote unquote, outside hospital at Texas Children's, actually this term is banned from Cincinnati. I don't know if you know that because it's kind of derogatory, right? Whenever we say, oh, patient presented from an outside hospital, the assumption the resident's making is they came to Stanford, we're better, or they came to Texas Children's, we're better, we're gonna fix the problem. But in any case, outside hospital in quotes, direct comes in at 3.9 the same day they come to Texas Children's, conjugate is 2.3. The first instinct for most residents is, oh, they went to the county hospital, they don't know how to do tests. Not true at all. The county hospital uses direct. So the direct measures, as it shows here, conjugated 1, conjugated 2. There's 2 versions of conjugated, depending on how you change the residues. It measures delta and a little bit of unconjugated. So it's going to, of course, be higher than the conjugated, which measures just conjugated 1 and 2. Okay, so directs are always a little higher than conjugateds. And for that reason, and for the reason of a chemical reaction, for the direct measurements, it's critically important that a reference range is derived. Now, many of you might think a reference range, of course, labs already do that, but in fact, many labs don't. They borrow reference ranges. You can't do that for direct because there are subtle things about the way the reaction is run, temperature, pH, and length of time, where each lab should take 120 kids measure it, plot it on a scale, and then the middle 95th percentiles are normal, and anything above that wing is considered abnormal. So it does require us to derive reference ranges for the direct, at least. Conjugated is very precise. It goes across institutions, but directs need a reference range. Okay, sensitive and specific. So is it valid? And that essentially means the diagnostic accuracy things that we labored over in medical school to make sure we don't get confused about. Sensitive and specific. Sensitive, if you have the disease, you'll test positive. Specific, if you don't have the disease, you'll test negative. Okay, so what do we have? So this was the pilot that I talked about, and showing the data in a little bit of more form that you might be more accustomed to. And you can see we did the first test for the 121 that tested positive, they get retested. And how many had biliary atresia? 2 of them. You can see the net sensitivity specificity look really good from a screening perspective, though I will tell you 99.9%, even though that looks great, that still means 0.1% of the population is false positive. Multiply that by 4 million kids a year. It's still something we have to think about. This was a small pilot study, and then we extended it to Houston. So this is our great city. 3rd largest city, sorry to people in Chicago, I think we passed you, but 3rd largest city in America. And we've put screening wherever we can. And we monitor these kids. And a really interesting phenomenon, and then, sorry, this red dot is actually up in the right corner, is the border, a border town right at the Texas-Mexico border, who's also on board. These halos represent the fact that primary care doctors in the screening sites, they also serve other hospitals, and they realize, hey, this actually might work. And so they've sort of spread it out to other areas. Some people in our group like to call it herd, like the equivalent of herd immunity. You get the benefits without actually being part of the study. And here are the results. So this was a big study, 120,000 in Houston, in 14 different hospitals. And you can see how the numbers shake out. 7 were biliary atresia, all were caught, and sensitivity, specificity, very similar to what we had before. Okay, still, let's think about this. What about these false positives? Well, first, let's look at them. There were 112 false positives in the big study out of 120,000. What did they have? Well, what's interesting is these diseases are kind of interesting. They're not things like false positive, meaning there's nothing. These kids still have something. And the point is here that from the liver doctor perspective, we care about catching Alagille syndrome. We care about catching alpha-1 antitrypsin deficiency, and we get it from this screen. It's not the primary purpose. You don't really get a huge advantage of catching them in the first day of life, but at least we know they're there. We could start giving nutritional rehab and making sure, for example, their INR doesn't go out of control because of vitamin K malabsorption. So there were some things that were important in some infections like syphilis and other things. Now, I think one question that's going to come to your mind, we do not want to subject parents to unnecessary testing. And this is the evaluation performed. So around 25% needed just a direct bilirubin. They didn't need anything more, just another direct bilirubin, just to watch it clear. More laboratory testing in 22%. And then I'm going to say after that, it gets invasive. And the reason why I say invasive is because that non-invasive imaging, that ultrasound that the next 33% needed, that child actually has to fast for 4 hours. And that's not exactly non-invasive. To ask a newborn to not eat for 4 hours to get a good ultrasound, to me, is pretty disruptive to the family. And then, of course, a liver biopsy, I think we'd all agree is disruptive. And intraoperative cholangiogram, 1 patient needed it to rule out biliary atresia that did not have biliary atresia. What were the results? Well, I think sort of this slide says it all. Before screening, look at our Kasai date. We already talked about the average Kasai date, greater than 60 days. And then after screening, I mean, it's plummeted. You can see the median, I think it's around 23 days. If we Kasai after 30 days in our institution, we are now asking the question, what went wrong? Why did this patient come to us after 30 days? And again, I want to emphasize, it doesn't matter if you're dark-skinned or light-skinned, rich or poor, we've got it all in Houston, and we ask the same question. If you come after 30 days, what went wrong? Okay, number 7, is it affordable? The expertise for this type of question is in this institution. And the verdict is still out. Is it, the term, I guess, is cost effective? And in other words, the money we put in, is it worth the benefit we're getting out? It's fair. If we were going to go to anything we do in medicine, we should probably ask this question, even though we don't ask it enough. But is it fair? We don't know the answer to that. Maybe we will soon. These types of studies depend on a lot of assumptions. And so from my perspective, I don't feel as comfortable with these types of studies because it depends on the assumptions you make. It gets, in my mind, because I'm not good at this, it gets a little flimsy. In other words, I can manipulate the assumptions to get the conclusion I want. But just look at the costs. So a direct or conjugated bilirubin measurement, if you go to Texas Children's and you pay out of pocket $240. Okay, this is the state of our healthcare system. This is no surprise to anyone else. If you do it at cost, it's around 25 cents to $2. Okay, why is this? We can talk about this, but health policy experts can explain that this type of up cost, no one actually pays except people who pay out of pocket. They're stuck with the bill. They go into debt. They're paying for everyone else in the system, including our salaries. The other things, congenital heart disease, these probes are, around $10. The blood spot, probably the best deal in town. I don't think there's any lab tests where you screen for 50 things and only pay $30. And hearing tests are quite expensive. And here are the potential savings. So this is, again, back of the envelope. Forgive me for any experts in cost effectiveness. I'm not saying this is definitive at all, but I did want to emphasize the fact that a transplant less than a year versus greater than a year, completely different propositions in terms of cost. And the reason why is you can see the admission days are different. The ICU before transplant's different. The prolonged intubation is different. The renal replacement therapy is different. And so as a result, the costs are different. It's cheaper, if that's the most important thing. It is cheaper, much cheaper to do a liver transplant later on than early. Okay, so summary for part 2, the test. Pediatricians, hopefully it's acceptable, but pediatricians need information on the importance of the direct versus conjugated. This is probably not as well known as it should be, but hopefully we can all sort of explain this to people in the future. Bilirubin levels can be measured differently. We talked about direct versus conjugated. The test is both sensitive and specific. Again, there is still a 0.1% false positive rate, which this institution, along with ours, is working together to really work on. And then savings may offset the cost of screening, or at least be acceptable for what we gain from screening. So there's a knowledge issue. What do we do with the high value? Pediatricians still need to understand that, and we are working hard with the AP to make that clear for them. There's an infrastructure issue. You have to get reference intervals for directs. Transcutaneous measurements will not work. You have to do blood. They do not tell you about directs or conjugateds. And then this age-old problem in our field, how do you communicate all the good stuff that happens in the nursery to the primary care office? And this is only one small sort of symptom of that. Obviously, this problem runs deep, and there's many fields that suffer from this. And then other issues, acceptable reliability and reasonable cost. I promised I'd finish at 8:50. I'm going to go over just by a few minutes because I'm just going to run through 2 cases just for fun to show you how this works. 97-day-old male presenting with jaundice. This was a blue-collar worker, construction worker in Houston, in a suburb of Houston. And this dad had the day off, so he took his 5-year-old son in to the primary care doctor. And he had been telling the primary care doctor, the other kid, the newborn, looks really yellow. And the primary care doctor at 2 weeks and 2 months just said, put up in more sun, typical stuff. And this guy, he didn't want to get in anyone's way. He didn't want to presume he knew more than the doctor. But at 97 days, when he took the older 5-year-old in for the well child check, he said, "Doc, I hate to disturb you." It's funny seeing him. He's this big guy, but very soft-spoken. And he said, "I hate to disturb you, but can you just look at this one, because I don't think this yellow's right." And there, the doctor said, "Yikes, you're right. Send him in straight." This baby, though, was 50% off for weight. But when you pried open those eyes, when you pried them open, which is hard enough to do for those of you in your nursery rotations, they were yellow. Okay. Incidentally, I put jaundice and icterus here. Those are actually the same thing. For those of you who I learned from a reviewer on a paper, they're the exact same thing, jaundice and icterus. So what do we do right away? Email goes out to the entire half the hospital. Residents are at the top of the list. In our institution, just like yours, probably residents only one letter away from presidents. They run the show on the floor, so they get called, and then they call everyone else. Surgeons need to be called quickly. Interventional radiologists need to be called quickly. Pathologists, dietitians, just everyone. This is turned into a crisis. We got to work fast. We did work fast. We went down an evaluation, and you can see it. We looked at the conjugatability was high at birth. Day of life one, or day of one, sorry, with us, they did all this testing, which I'm not going to talk about, but I can. We're really accelerating this process even more to limit the amount of testing. But the key is on day 2 to 4, they got their liver biopsy, and we had to stop. We didn't proceed with the Kasai, and the reason why was the liver was just a fibrotic organ. There's no point in sewing an organ to a fibrotic organ. This child went straight to liver transplant listing. Livers don't fall from the sky. This child spent literally the first year of life with us, close to death multiple times. I don't know if any of the GI doctors have ever had to put a tube down the esophagus and inflate a balloon to prevent variceal bleeding, but this was a patient where we had to do it. We don't like to do it very often, but this was how critical it was. This mom was a social worker, and I think that was the only thing that kept this family together. And there was this. So this hospital was not on the screening grid. It is now. And you can see this patient, for whatever reason, had 4 bilirubins in the first, before discharge. In every single direct, bilirubin was high. This was never passed on to the primary care doctor. It was never followed. In theory, this patient would have been caught early and diagnosed early, treated early with something in place. Case number 2. This is the last one. 2-week female referred for an abnormal screen. This was at Texas Children's. The resident, again, to pay tribute, was the hero. At day of life 2, it was 0.5. The resident told the family, slightly high. At 2 weeks, we have to recheck. 2 weeks came around. The parent went to the primary care doctor, all the niceties that happen with primary care on a first child. And it was Christmas time. I remember mom packed up the baby. It gets a little cold in Houston sometimes, and started heading downstairs, and then said, wait a minute, that resident mentioned something, and headed back upstairs, told the primary care doctor. The primary care doctor actually got a message from us. So pediatric hepatology helps this process by connecting with the primary care doctor. They said, oh, I remember, I got an email from someone, that was me, rechecked it. And here's the recheck, 2.33 at direct. Here is the stool color. And the only reason why I said slight icterus in the eyes is because I saw this result. So when I peered open the eyes, I said, yeah, it's probably a little yellowness. There's no possible way anyone should be expected to see that. And the stools, I think you guys can see, it looks pretty good. This baby, here are the labs, conjugatability 1.7 with us, always a little lower than the direct, as we talked about. GGT was high. For the bright medical students who hopefully will go into pediatrics as opposed to pediatric surgery, because we can convince them afterwards, AST and ALT are normal. So for the shelf question, this is the reason why we don't ask pediatricians, put the burden on them to say, get liver panel and then send them over. Because if the pediatricians were like me on my first 2 patients with biliary atresia, 2012, both who I was responsible for delayed diagnoses, and the reason why is because of this, AST and ALT were normal. And I thought there's no way the most fibrotic liver disease known to man would have normal AST and ALT ever. In fact, though, it wasn't me alone. I presented in our case conference multiple weeks, and everyone in the group agreed. So knowledge is shifting slowly. That's why I was surprised it made it to the shelf, but knowledge is shifting. Here's the liver biopsy. And we already talked about blue being bad. This liver is scarred. 23 days of life, this liver is scarred. Even the edges of the liver biopsy should be straight. They're jagged. And the reason why is it's a cirrhotic liver. Did a Kasai at 26 days. Here's the growth curve. It's anecdotal, but it's fun to see because this is success. No child will grow if their bile isn't draining and they're absorbing fats. No kid will have a growth curve like this. Okay. So last slide, summary. I hope I convinced you that biliary atresia as a disease should be screened for. And that's regardless of whether or not we agree with the test. Biliary atresia as a disease should be screened for. We proposed a newborn screening test that potentially could solve the problem, that does have its limitations that we're working on and that we can talk about more. But most importantly, there is a special opportunity here for all of us to move the field, to advance beyond what was given to us, to move the field, importantly, to make sure that, again, it doesn't matter where you were born or who you are or who your parents are, you can receive equal benefit and potentially avoid or at least delay need for liver transplant. So I'd like to acknowledge this is the same slide you saw initially, but again, in a little bit more granularity, you can see the different hospitals. For the NEO folks here, I hope you see people you know. These people were instrumental in pushing this through, especially Dr. Garcia Prats, who runs the NEO service at our county hospital, and Dr. Guillory, who's also sort of running the AAP side of fetal medicine. And then also, of course, people in our liver center, and we actually have a dedicated biliary atresia team to take this seriously and deliver sort of uniform, hopefully excellent care for our patients. So this is my email. And again, Sohail and company, Amrita, wherever you are, thank you guys for inviting me, and I'd be more than happy to take questions.
Wow, that was wonderful. I think your talk reiterates the point that knowledge is power, science is blind, and biochemistry can break barriers.
Biochemistry can break barriers.
So let's open it up to questions. And let me just say that I'm told that we have to end at the hour formally, but informally, we have time here in this auditorium so we can continue informally. Please.
Thank you. That was a fascinating talk. Appreciate it. Can this test be run on the standard newborn screening sample?
Yes. So the question is, can it be run on the blood spot? And the answer is, well, I guess I'm a product of this institution. And the answer is, it's never no, but the answer is not yet. So stay tuned. This molecule degrades with light. And so this has introduced me to the wonderful world of mass spectrometry, which I was never trained in, but sort of hardcore chemistry that Michael Fishbach, who's about to talk next week, can teach you all about. But chemistry is amazing, and solutions are potentially available. The problem is, though, if it's on the blood spot, just so we know, one limitation, one advantage is universally test everyone at a central lab. One limitation is at Texas, they work hard. I work very closely with the state on this to get a turnaround at around 5 to 6 days. So there's a little bit of a delay. That's okay. If we can get off the spot, we're going to go for it.
Hi, Lisa Chamberlain. I'm our Associate Chair for Policy and Community Engagement and Director, Office for Child Health Equity. So thank you for all the equity lens you brought to this fabulous talk. Where is the AAP on their policy statement on this? What's your time horizon?
Do you know something that you didn't say? No. So who is involved in the AAP? Okay, we've got at least two. So AAP, American Academy of Process and Pediatrics, process. So the AAP is incredibly diligent, and I'm putting a positive lens on this, and the reason why is because we're coming to the end. So I said in the AAP section on gastroenterology, hepatology, nutrition, our mission is medical education, not in a paternalistic way, but in a collaborative way with primary care doctors to improve the referral process. Equity is number one there, right? And so the reason why I joined this group initially, it was sort of a biased perspective. It was to bring this issue to light. So 4 years later, probably 15 to 20 algorithms later, just last week when I was overseas, I got a message saying, we're there. So the clinical report's going to come out, and it's 4 years later, so it's a lot of process. But the point is, there's going to be a rhyme. We had to do something. So every primary care doctor is equipped with it until screening becomes universal. And the idea is step one, you'll see the algorithm. I can't show it because embargo from the AAP. Step one, step two, step three, check eyes, then poop, then first Billy. And if you emphasize the E on Billy, it rhymes with 3 and it works. So the idea is exactly this. We're going through the AAP to reach every primary care doctor, not in a punitive way at all. We're not saying it's your fault. I didn't show you data, but we were able to decrease the referral time, but the amount of time we spend evaluating the patient when they come to us didn't improve. So it's not only a primary care doctor, it's our problem also. But the AAP, through the AAP, the clinical report is about to come out, and this is something that we can share with every primary care doctor. It turns out one of the mission statements of this institution is digitally driven. I don't know if you guys knew that. I learned it yesterday. And Teb, who's a fellow, and I are, we are about to make this in a digital way that should be accessible to any primary care doctor, not in the US, but any primary care doctor in the world. So we're sort of trying to fit that mission statement. This is a simple solution. There's nothing complicated about this, but I think what you realize in your line of work is it's the simple solutions, vaccinations, right? Stuff like this. It's the simplest solutions, which are the hardest to get people to grab onto. And so we're trying to hit it that way.
Great.
Thank you for asking. That's why I asked if you knew anything about the clinical report.
Well, we will need to formally end, so let's give a round of applause to Dr. Harpavat. And again, we have the room for a few minutes. For those who are online, and if the online's still available, let me just rapid fire through some of the questions that came up. And then if there are other participants who'd like to ask questions here, feel free. So this will be rapid fire. So
okay, rapid. Let's do it.
Short response.
Okay.
In the 1970s, an article on biliary atresia was related to amphetamines during pregnancy. Do you know anything about it?
I don't, but I would love if someone could email it to me. The problem is, the question is basically environmental influences causing biliary atresia. The way to think about this, I would say for the questioner, is no twin pregnancy has ever been shown to both have biliary atresia. And you would expect, in my mind, in a simplistic thinking, that if a mom was taking amphetamines, somewhere along the way, the environmental influence should affect both twins. But if you could forward that, I would love to see it.
Great, thank you. And the second questioner discussed being digitally driven and asked about smartphones for photos of skin or stool.
Yeah.
Can you actually integrate the color of the image into a device that identifies through AI?
Yeah.
You know, the problem?
Answer is yes, definitely. There's a investigator named Doug Mogul from Johns Hopkins, was from Johns Hopkins, now went to biotech, and he developed a Poop MD app. The only problem with that, again, is for whatever reason, you have children with obstruction of the bile ducts that still have colored stool initially. So you're not going to pick those kids up. But down the road, the answer is yes. It's a multi-pronged approach. Step 2 of this rhyme is check the poop. So I think we should use it.
Thank you. And some of the questions are really cool here. So I might, if you don't mind,
Sure.
rapid fire through some of the more of them. So a deeper question, and pun intended maybe, is to dive deep into the poop, which is about bile itself.
Yeah.
Why not have a biochemical test of the stool for bile? Would that be helpful?
Yeah, I think for bile, meaning bile is made up of a few things, but I think what you're getting at is a biochemical test of pigment or bile acids in the poop. And I think it would be interesting and helpful. I think the issue is getting the sample. I should say yes, that could definitely be possible. And we should think of all options on the table to solve the problem. But yes, people look at, you can measure bile acids and you can measure pigments in stools biochemically, which could potentially lead to a solution. So whoever asked that question, if it's worth pursuing, I mean, obviously I'm in. And if you want to work together, we have a setup here, you have a setup, you have a setup here, we have a setup there. And we can start to, we've started to ask the question a little bit and we can continue.
Great, and that was Dr. Ed Leibovitz.
All right.
If you want to follow up with him afterwards. The next questioner had a longer question, which I'll summarize, and it had to do with cost effectiveness. And they quote, and you'll have the comments here, quite a few numbers about cost effectiveness ratios. I think the question is, do we have the resources from as a healthcare agency, federal government, to do newborn screening for biliary atresia?
Yeah, I'm assuming for biliary atresia, right?
Right.
So this is a question. This is a question where we have to ask ourselves. In a world where resources are limited, do we think the disease is important enough? And if we think it's important enough, then we figure out a way. We make the test cheaper if we need to. We figure out how to deal with false positives faster. These are all things we're doing. That's why I'm bringing it up. And so our fundamental goal is to, as long as you agree with the first part, the disease is worth screening, then we're going to solve the second part, which is it cost effective? So I don't see that as an impediment at all. I think the only reason why I'm here is a work in progress, not a solution. Like I told someone before, if I was going to give you a solution, I'll go to the community hospital at Kaiser and give this talk and say this is what to do. So when I think more in the mindset that we can always do better, we can always make things cheaper, as long as we agree with the fundamental principle that this disease is worth screening for. And I can tell you, every liver doctor in the room and every patient that's affected by biliary atresia will say yes. I mean, it's hard for me for someone to imagine someone saying no. So the cost-effective part we're working on, and any data you see today, I will tell you, will be outdated tomorrow because we're making some rapid progress in this.
Thank you. There are several other questions. Maybe I'll just ask the last one, which comes from Dr. Phil Sunshine, a neonatologist, who asks whether you've considered or others have considered using a GGT as a screening tool besides the bilirubin conjugated or direct.
Great. Dr. Sunshine, thank you. So these are sort of the end of the slideshow slides. Here's the GGT distribution for these kids at presentation. So the problem is it's all over the map. So it's not great. We don't understand why, but GGT doesn't seem to sort of have a correlation with time or have any consistency. One more thing, Dr. Sunshine, I'll add is actually this. So this idea of finding a ratio of direct to total. So believe it or not, this idea was shared first by someone from Texas Children's. Her name's Virginia Moyer. She did 1 year of GI fellowship. That's it, and then left. And it's amazing. Some people are just phenomenal. And she ended up writing guidelines for our society as a first-year fellow and then left. What did she leave for? Well, she left to do general medicine, and she became the head of the United States Preventive Task Force. That's a big position. She was Time Magazine's 100 Most Important People 1 year, not for bilirubin stuff, but for prostate screening in her organization. Bottom line is she published a paper saying a ratio greater than 0.2 or 0.15 is the only time to worry about the high direct. Because the idea is the direct could be high, but if the total is high as well, it's just a whole bunch of unconjugated. It's not liver disease. Yet we found something quite different. And you can see this graph here when you look at the ratio. In the children with biliary atresia, there's a whole lot of children with a ratio less than 0.2. So just because a child has biliary atresia, they can also have hemolysis for every other reason the newborn has it, which will drive up the total. So it's really absolute direct, which you find is the best. So really GGT doesn't help us much. And the other problem with GGT is it requires a separate test. However, Dr. Sunshine, maybe what you're thinking is GGT, you can probably measure a lot easier off the blood spot, but the problem is GGT is not reliable. The direct or conjugated absolute, not ratio, seems to be the best thing we have so far.
Awesome. Does anyone have any other questions or comments? All right, with that, thank you again.
Thank you. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.